So I would be discussing the TPN practices at HIMS. I would like to thank my moderators, Girish sir and Chinmay sir. So moving ahead, the specific learning objectives for today, the indications that are set up, the components which is required for the preparation, the parenteral nutrition prescription, routes, the administration, monitoring, complications associated, the TPN apps, what we are using, the void in our practices, and the take-home messages. So the most common indications at our NICU, if of course the gut line can't be used due to any reason, extremely preterm babies, gut ischemia, gut injury or inflammation, surgical conditions, and infants too sick to receive enteral nutrition, shock requiring high dose of inotropes and pressors. So in these cases, we are going for TPN, but of course, from the TPN, we want to switch to the, we are taking care of the partial parenteral nutrition, and then of course, switching back to the enteral nutrition as soon as possible. So start the enteral feeds as soon as possible. Then the components, the macronutrients by carbohydrates, lipids, and proteins, and micronutrients by minerals, vitamins, and trace elements, and the energy derivation 40 to 50% from the carbs, and 30% from lipids, 15 to 20% from the amino acids. So in carbohydrates, we are starting with the 4 mg per kg per minute, and we're gradually increasing by 2 mg per kg per minute and up to maximum of 12 mg per kg per minute. And at this point of time, the RBS is monitored. We're trying to keep it in between 60 to 145 mg per deciliter. And the other side is the recommendations. Then the non-protein calorie nitrogen ratio, the CNR, it is measured time to time. And the derivation, the formula for this is the total non-protein calories divided by grams of nitrogen. And the target, what we're using is 150 to 250 kilocalories per gram of nitrogen. In proteins, we're starting with the 10% of amino vein. We're starting soon after the birth in the babies where the weight is less than 1500 grams. We are starting from 2 to 3 grams and we are increasing to the target of 3.5 to 4 grams per kg per day, depending upon the growth of the baby. And if the baby is more than 1500 grams, then we're starting with the 2 grams and increasing to 3 grams per kg per day. So the 10% amino vein, what we are using, then this is coming in 2 preparations by 2 companies. And then we have the lipids. So we're starting with 1 gram per kg per day, and we're gradually increasing up to 4 grams per kg per day. The lipid, what we're using at our setup is SMOF 20%, and this is 30% contains 30% of the soya bean oil, 30% of the MCT oil, 25% of the olive oil, and 15% of the fish oil. Now it has its own advantages: higher DHA, the sepsis rate, cholestasis, TPN-associated liver dysfunction, oxidative stress, and the phytoestrol load, they're all decreased by this. So we're using the SMOF, but in case of the logistic reason, if we do not have SMOF, then we are definitely going for the intralipid, which is 20%, the pure soya bean-based oil. So monitoring, we are going for a triglyceride levels. We are going generally at first 2 days, we are sending a triglyceride level, and after the initiation and adjusting of the lipid infusion. And when we are adjusting the lipid infusion, we might send at that time as well, and thereafter we're sending it weekly. So when the serum triglyceride level is more than 265, we're considering to decrease or stopping it depending upon the status of the baby. And in the electrolytes, we're going for the sodium. We're starting with 3 MEQ per kg per day with potassium of 2 and chloride of 3. So electrolytes, we're adding on the maintenance fluid after 48 hours of the life. These are the recommendations. What we are going, instead of the KCl, we're going for a pot phos. So I would want to just throw some light in this. So 1 ml of pot phos has 93 milligrams of phosphorus and 4.4 milliequivalents of potassium. we're giving by 0.5 ml per kg. And when added to the TPN IV calcium, we're using it separately to avoid the precipitation. And this is definitely reducing the risk of metabolic bone diseases at our setup. And I would also want to show some, so early supplementation of calcium and phosphorus, we are taking care of, again, in view of preventing the metabolic bone disease. So early supplementation involves calcium of 40 to 80 mg per kg per day, and phosphorus of 30 to 60 mg per kg per day. Then vitamins, we are going for a adult multivitamin preparation. Although the recommended vitamins for the newborn in the TPN has this adult vial doesn't contain the vitamin B12, ascorbic acid, and folic acid. So this is one disadvantage, but we're using this, and vitamins we are using along with the lipids. And to avoid the photo degradation, we're using the dark papers or the aluminum foils. And then in micronutrients and trace elements, these are the recommended dosage in the newborn. What we're using is the OTSKI as a trace element. So this injection is of 3 ml, and 1 ml contains zinc of 1 mg zinc, chromium of 4 micrograms, and selenium of 22 micrograms with copper of 0.4 mg, manganese of 0.1 mg. And the dose what we have calculated roughly, if we want to cover the recommended intake in the babies, is 0.2 ml per kg per day. And this is costing us 163 rupees. Then other additives other than this, to make the TPN comprehensive, we are also going for a carnitine. In our setup, in the cases in which we're using is cardiomyopathy, as well as, of course, in the metabolic encephalopathy babies. Then a cysteine may be considered. We are not using it regularly in preterm babies for the essential amino acid, and it may be supplemented. It is supplemented as 30 to 40 mg per grams of the protein. Heparin we're using for the patency of the central venous catheters. We're adding it into the TPN by 0.5 unit per kg per hour. And despite of the fact that the baby is on TPN, we are practicing the buccal colostrum application and subsequently non-nutritive sucking depending upon the status of the baby. Then this is a TPN prescription for a 1.1 kg baby on day 4 of life. So the total fluid intake would be 140 ml per kg per day. This turns out to be 154 ml. With in the carbs, we're giving 10 mg per kg per minute, and that turns out to be, for this weight, 15.8 grams per day. Then since the baby is NPO, so then we're adding the proteins by 3.5 grams. That turns out to be 38.5 ml of aminovein. Similarly, lipids, MOF we're using. So this, for this weight, it turns out to be 22 ml and 3% NaCl, 6.6 ml with phosphorus, 0.6 ml, MVI, calcium gluconate, magnesium sulfate, and OTSKI. So this all turns out to be 75.3 ml. So the fluid left for carbs, so this is 78.7 ml. So we have calculated the dextrose. So now we're mixing the two solutions. In one solution, we have aminovein, the sodium chloride, phosphorus, Maxer, OTSKI, and the dextrose. And in another solution, we have the lipids and MVI. And we are, of course, using the calcium gluconate with a different peripheral line. So we have a TPN room at our center with the laminar flow. And so these are the pictorial presentation all everywhere in the TPN room. And so the preparation of the TPN, we are going for a laminar flow. We are cleaning with the disinfectant, the sterile sheet spread inside the laminar flow. The UV light is switched on for 30 to 45 minutes. Then the required materials are kept inside the laminar flow. And after cleaning each one of them with disinfectant, then we're using it. We're switching on for the light for 30 to 45 minutes, and the lipid, MVI, they're all cleaned by the chemical disinfectant and kept under it. And after switching off the UV light, the TPN is prepared after wearing the cap, mask, gown, gloves in a complete sterile manner after switching on the laminar flow. TPN is connected to the patient, and the bottle along with the tubes is to be changed every 24 hours. So the TPN with enteral nutrition, encouragement of TPN with enteral nutrition we're doing, and as TPN without enteral nutrition would lead to a decreased mucosal IgA production, the lack of trophic hormones, increased adhesive molecules and neutrophilic attraction, the TPN associated sepsis, SIRS, and mucosal atrophy, and hence we are trying to encourage the partial parenteral nutrition rather. The routes, what we're using is either central or peripheral. Peripheral only if it is given for a very short period. Otherwise, predominantly we're using a central lines for TPN. For the extended period, if the TPN is required for an extended period, then a use of double lumen catheter lowered the number of additional venous placements, but it was seen to be clogged, leaked, and broken more often. Then we have, so the preferred route is a central line, UVC or PICC. Then we have a single lumen versus multiple lumen. So we have seen that the double lumen catheter lowered the number of additional venous placement, but then it has its own drawbacks, clogged, leaked, and broken. PICC and tunneled CVC should be used for administration for prolonged parenteral nutrition during hospitalization. And the practice, what we are obsessed with and we are following it, is the catheter connectors, ports, and hubs to be disinfected before accessing with 70% isopropyl alcohol or sometimes chlorhexidine. Asepsis, while TPN preparation and thereafter, we all should be obsessed with the asepsis, and we are trying to create the awareness by in our NICU. Maintaining the OT-like preparation, all the fluid mixing and preparation under the laminar flow, infusion sets to be changed daily, the proper hub care is taken care of, and preparation solution we're not using beyond 24 hours. And inotropes and antibiotic is being given after checking the compatibility. Obsession with the asepsis, and then for the TPN, to prevent the TPN photodegradation, we are using the aluminum foil and the brown dark papers, although we have some lines also which are available in the market, but it is costly, hence we're not using it. Then bacterial filters, currently we're not using the bacterial filters because of the cost, but we're taking the aseptic measures while preparing it, so we're not using this. But we have two types of filters available. One is for the lipid lines, another one is for the one which is used for the aqueous lines. So the lipid lines, they're being changed every 24 hourly, whereas the aqueous lines 96 hourly, we're changing it. In monitoring, we simultaneously with the TPN, we are going for the monitoring every 6th hourly, we're going for a blood sugar. And initially we are using, we're doing it every 6th hourly, and later we are customizing it depending upon the status of the baby. Weight monitoring we are doing daily, but sometimes in the sick babies, we're customizing it to twice daily. Sodium, potassium, chloride, we're doing it twice weekly, whereas weekly we're going for calcium, phosphorus, magnesium, blood gases, CBC, LFTs, and anthropometry every weekly we're doing it. Which includes the head circumference and length. And triglycerides, we're doing it 1 to 2 days after initiation or adjustment of lipid infusion, and thereafter we're doing it weekly. So preparation should be baby specific and double check. Monitoring is key to successful therapy and managing the complications simultaneously. Weaning and stopping. The TPN at our setup, we are decreasing once the enteral feed of 50 ml per kg per day is achieved, and one may consider stopping when the enteral feeds are 100 ml per kg per day, and when TPN volumes are less than 25 ml. So using the gut line at the earliest, and enteral nutrition is more important than parenteral nutrition. Then complications, what we are facing mostly is triglyceride levels are high and neonatal sepsis. TPN difficult Neonatal multivitamin preparations is not available. Neonatal trace element formulations are not available. And in order to overcome this, we are going for adult preparations. And cost of, since it is the lipid cost is 1,000 to 1,200, it's costing us per day. So we are going for a sharing. And since we're doing it under the laminar flow, so we are able to maintain the aseptic precautions here. Lab investigations and monitoring, sometimes it is, but mostly we're not facing this. Wide range in practice in parenteral and enteral nutrition, and smaller dispensing bottles, which is not available. So drug compatibility with TPN, we are going for a drug compatibility checking. So this TPN is usually incompatible with mixing with the drugs like ampicillin, phenytoin, furosemide, and phenobarbital. Incompatibility to be mixed in Y connectors. We are taking the help of Neofax, Lexicom, Medscape, and UpToDate for drug compatibility checking. Then the available apps, we have the Neonatal AI, the Aspen Clinical app, the Neo TPN. What we currently using is a Neonatal AI. Most of the time we are doing a manual, but sometimes we're taking the help of Neonatal AI. Voids to fill in our practice is the logistic reason sometimes, because it's costly, and kabhi the Ayushman process is taking time, and that's the reason most of the time we're facing. And lack of training and attitude, poor record keeping. And the take-home messages here are that the metabolic and nutrient demand of preterm is equal or higher than the fetus. So we should start with the TPN as early as possible. Hours and not days are the longest periods which neonates should be left without nutrition, either enterally or parenterally. TPN should be comprehensive and not just for the namesake. Laminar flow system should be a part of every NICU. So this is from my side. Thank you all.